Before we get started today, a note from our sponsors.
This episode was brought to you by puppies. Snuggly and adorable, they'll always be your best friend.
Welcome back to BrainWaves Briefs. I'm Jim Siegler. We're going to do things a little bit differently in this episode. We're going to discuss the novel oral anticoagulants in stroke prevention. Mostly, what drug do you choose? First of all, let's state the obvious. Anticoagulation is indicated in nonvalvular atrial fibrillation for secondary stroke prevention. We know that aspirin plus clopidogrel was superior to aspirin alone in the active W trial. However, the combination of antiplatelet therapy was less effective than warfarin. That being said, we don't cut to the chase and immediately start patients on anticoagulation for secondary stroke prevention, so we anticoagulate stroke patients in certain instances. Low molecular weight heparin, ideally for hypercoagulability of malignancy, sometimes low molecular weight heparin or warfarin for cervical artery dissection, although CAT has found no benefit over antiplatelet therapy. We use warfarin for antiphospholipid antibody syndrome or in select cases of heritable thrombophilias, warfarin only for valvular disease and for systolic heart failure with apical hypokinesis, and then we have our non-valvular AFib. When compared to warfarin, the new oral anticoagulants offer several advantages. No routine blood tests, no interaction with food, limited interactions with other medications, and theoretically more time in the therapeutic range. But there are several disadvantages to the NOACs. Most require twice daily dosing, with the exceptions of Rivaroxaban and Edoxaban, which, despite their once-daily dosing, have a nearly identical half-life to Apixaban. Other disadvantages include that the reversal agents are currently unavailable, with the exception of Dabigatran, where you can treat with Edoxaban. Also, these NOACs can't be administered to patients on hemodialysis, and expense can be limiting. This may actually be the rate-limiting factor for acquisition of some of these drugs. So, let's get started. Which NOAC will you choose for a patient who has AFib and a stroke? The answer is Apixaban. We're still going? Okay. Alright, well I guess we can talk more about the different drugs. For most of you, this episode can end here with Apixaban. But for the rest of you who want to know about the differences between the NOACs, I'm happy to go over these other drugs as well. To make things more interesting, I've brought some toys with me this episode. My triangle, my gong, and my toy train. So they'll be joining us for this episode. Let's start by discussing the factor 2A inhibitor, Dabigatran. It's dosed at 150 milligrams twice daily by mouth, and it can be reduced to 110 milligrams twice daily in patients with lower creatinine clearance. It has a half-life between 12 and 17 hours and can be reversed by hemodialysis and with a new agent called Edoxaban. We know that from the RELY trial, the rates of major bleeding were actually lower in the low-dose Dabigatran arm, but were similar in the high-dose Dabigatran arm when compared to warfarin. Unfortunately, major GI bleeding was greater in the high-dose Dabigatran arm versus Coumadin. Rates of ICH were lower for both Dabigatran arms compared to warfarin, and this was found to be a superior effect compared to warfarin. Adverse events from the RELY trial included GI bleeding was greater for high-dose Dabigatran, and myocardial infarction was also more likely. There was no overall mortality benefit, and no mortality benefit due to any death from cardiovascular disease in the Dabigatran study. As in the Aristotle trial for Apixaban, the rate of stroke, both hemorrhagic and ischemic, or systemic embolism were significantly lower in the high-dose Dabigatran arm versus Coumadin. Moving on to the factor 10A inhibitors, Apixaban, one of the more favored factor 10A inhibitors, was associated with a lower risk of stroke or systemic embolism, as well as intracerebral hemorrhage when compared to warfarin. Rate of major bleeding was lower in the Apixaban arm at 2.13% per year versus 3.09% per year, and the rates of GI bleeding were equivalent. Apixaban users were also less likely to die from any cause when compared to users of warfarin, and to date only Apixaban and low-dose Edoxaban have been associated with a lower rate of death. Moving on to Edoxaban. Edoxaban also has a short half-life of 8 to 15 hours and is dosed once daily, as is Rivaroxaban. Currently, there are no reversal agents for this drug, making any episode of bleeding a complicated event. That being said, the rates of major bleeding are lower in Edoxaban users when compared to warfarin by approximately 1% per year. It was also associated with a lower rate of cardiovascular mortality and death from any cause for users of low-dose Edoxaban. The risk of major bleeding is dose-dependent, but overall the risk of bleeding is lower compared to warfarin users. When using stroke as an outcome event, high-dose Edoxaban was found to be non-inferior to warfarin, but low-dose Edoxaban is certainly inferior to warfarin for stroke prevention. The last of the direct factor Xa inhibitors is Rivaroxaban. This drug has a shorter half-life than the remaining factor Xa inhibitors of 5 to 9 hours, and like Edoxaban, it's dosed once daily. In the Rocket AF trial, the composite safety outcome of major and non-major clinically relevant bleeding was no different in Rivaroxaban versus warfarin. It was also non-inferior to warfarin with regard to the primary outcome of stroke, whether it's hemorrhagic or ischemic. The rates of MI and death from any cause were also the same between groups. Major bleeding was lower in Rivaroxaban users, as were rates of intracerebral hemorrhage. However, major GI bleeding was more common in patients who were treated with Rivaroxaban. When you try to conceptualize which drugs are more effective than warfarin for secondary stroke prevention, we look at the superiority data of each of the trials that have been performed. To date, only Apixaban and the high-dose Dabigatran arm were found to be superior to warfarin. Interestingly, these two drugs were also superior to warfarin for the prevention of intracerebral hemorrhage. Rivaroxaban was also associated with a lower risk of intracerebral hemorrhage as well, but was not superior to warfarin for the prevention of stroke. When looking at the safety outcomes, Apixaban, Edoxaban, and Rivaroxaban were superior to warfarin for major bleeding risk. No drug was inferior to warfarin for major bleeding, interestingly. However, major GI bleeding was more likely in the higher dose Dabigatran arm, as well as Rivaroxaban when compared to warfarin. Patients who received Dabigatran were also more likely to have a myocardial infarction when compared to warfarin. And finally, perhaps the ultimate outcome for clinical trials, death, was lower in patients who received Apixaban or low-dose Edoxaban. In summary, if you have a patient with stroke and nonvalvular AFib, you can treat them with a novel oral anticoagulant as long as they're not on hemodialysis. For patients with a normal renal function, they should be treated with Apixaban. Dabigatran is a safe secondary alternative because it has a lower risk of secondary stroke. For patients with a stroke and nonvalvular AFib who have a DVT or PE, these people can be treated with Apixaban, Rivaroxaban, or Dabigatran. Patients who have coexisting coronary artery disease or peripheral artery disease, warfarin has been best studied. No comparisons have been made to date, but a NOAC is preferable. For patients who have an acute coronary syndrome, also NOACs could be preferable, but dual antiplatelets may be necessary. In patients with a high risk of GI bleeding, you want to avoid Dabigatran due to the major risk of GI bleeding, so Apixaban is preferred. And given the reversibility of warfarin, you may want to choose warfarin over Dabigatran. For patients with stage 3 kidney disease, Apixaban is preferred over Rivaroxaban and Edoxaban, with Dabigatran and warfarin being less favorable. You'll still probably want to go with Apixaban. That's all we got for you today. Thank you so much for listening to BrainWaves.
like what you just heard, you can find more related material on Twitter at BrainWaves Audio or contact us at bweditorialboard@gmail.com. Be sure to check out our iTunes archive for older episodes. This episode was produced by Jim Siegler. Music by Josh Woodward. Please join us next time for another edition of BrainWaves.